This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been coming to you since October of 2016 with pediatric hospital medicine topics. This is a continuing medical education podcast, and we've been enjoying it. I know I took some time off, and that was not purposeful. We're back at it now. We have just been, like you, super duper busy with things we shouldn't be busy with this time of year. RSV, flu, now COVID's back. We have not missed you, COVID, but we're here. We're talking about a topic that has really popped up. Now, unless you've been living under a rock, and God bless you if you have been, you're probably doing well. You've noticed, especially if you work in inpatient pediatrics, that there's an increase in adolescent and pediatric mental health disorders that are being admitted. And one of the ones that are being admitted way more than I ever remember are eating disorders. And I have seen a lot more kids with them, and they have been younger than I've ever remembered. And it's been something that has bothered me on many levels because it's a sad condition. It's a dangerous condition, and I'd like to know what's going on, why, and how we can do something more. So along those lines, I have asked one of the experts nationally here to come help us, and she has been kind enough to give of her time. So let me introduce our expert guest today. We are happy and proud to be joined by Dr. Amanda Downey, who's an assistant professor of pediatrics and psychiatry at the University of California, San Francisco, who provides integrated care for adolescents and young adults with eating disorders. She is the Assistant Medical Director for the UCSF Eating Disorders Program. Dr. Downey earned her medical degree at the Icahn School of Medicine at Mount Sinai. At the University of Pittsburgh Medical Center, she completed residencies in pediatrics and adult psychiatry and a fellowship in child and adolescent psychiatry. Through education, advocacy, and research, she strives to dismantle the systems that increase risk for eating disorders and improve evidence-based eating disorder treatments. Her current research examines disparities in access to treatment for underrepresented minorities with eating disorders and how to safely implement inpatient medical refeeding. Dr. Downey is a member of the American Academy of Child and Adolescent Psychiatry, the Society for Adolescent Health and Medicine, and the Academy for Eating Disorders, where she serves as co-chair of the Medical Care and Standards Committee. Dr. Downey, it is a pleasure to see you.
Oh, thanks for having me. This is really a treat, and one of my favorite things to do is to talk with pediatricians about eating disorders.
Now, Amanda, we have to, before we start, do our conflict of interest statements because we are a CME podcast. I will go first and kick it out to you. I have nothing to disclose.
No, I am aspiring to have something to disclose, but not yet, Tony.
Okay, good. Well, Amanda, let's start with the beginning here. These rise of inpatient admissions for eating disorders, and I guess rise of eating disorders in general.
Yep.
What data do we have for how long this has been going on? What did the pandemic do to this in terms of the amount of eating disorders and admissions for them?
Yeah, it's a great question. You know, I think this rise in eating disorders has been building really since 1999. We saw the beginnings of a pretty impressive spike in eating disorders, but certainly it seems that the pandemic tip this over the edge. Right now, we're seeing really unprecedented outpatient and inpatient volume in terms of eating disorder care. And that's not just in California. That's not just nationally. Those trends have really been seen internationally across the spectrum. And we're talking all ages, all genders, all socioeconomic statuses. And maybe we can talk about that a little bit later. But this problem has spared no one and no region really across the world. When we look at studies that have tried to kind of quantify what's going on, One big meta-analysis looks at like over 5 million young people and finds that the overall incidence of eating disorders has increased during the pandemic by almost 15% compared to the previous years. And really, when we just look at pediatric data, and when I say pediatric for eating disorders, I'm talking about adolescents and young adults up to about age 26, we see a significant increase in both outpatient visits, ED presentations, and inpatient admissions. And most of that data is out of Boston. But I can tell you here at UCSF, our inpatient census went, we had about an average of 3 patients who were inpatient at any given time in 2018. Now we're well above 8. I just came off service and we had 14, and that has not been unusual. So I think we are all kind of scrambling to find resources and evidence-based care and empowering our pediatricians to really take ownership of these young people, because this is just unprecedented.
Now, Amanda, if you've listened to the show ever, you know I like to blame, and I blame social media for a lot of things. What has caused this? Is this the big Facebook leak for Instagram that we all read about, where they were not shying away from their algorithm if it pushed people into more eating disorders? Or do we have any idea yet?
Yeah, I think it's a really good question and a really nuanced question, Tony, right? I think what we saw with the pandemic is that so many young people lost coping mechanisms, right? That maybe we didn't even realize were coping mechanisms before: going to school, doing sports, hanging out with friends, whatever. So I think the abrupt loss of those things for the vulnerable young person absolutely was a tipping point, right? We say that eating disorders thrive in isolation, and quarantine was nothing but isolation for many of our young people. So that's social media side, but let's talk about social media then, right? We know from evidence that social media has or can be viewed through the lens of behavioral addiction. There's something about it that almost mimics substance use, right? There's an addictive quality. We build tolerance to social media. We want to scroll more, find the next big thing. When we don't have access to social media, we get irritable. We kind of crave it, right? My phone was broken last week, and I even noticed that in myself, right? Like this desire to be able to scroll and maybe distract myself from whatever emotions I was feeling. So, if we again go back to social media through this kind of addictive lens, I think it can only be viewed as harmful. Then we take it this next step, right? Let's think about the way the algorithm works for the vulnerable young person who's not happy with their body or interested in getting fit, right? They start to find those things on social media. And then the way the algorithm works is that content gets pushed to them more and more readily. And so again, going back to this addiction model, right? You're getting more of that content, getting that little dopamine hit, and it becomes almost an impossible cycle to break unless you're asking and empowering caregivers or parents to step in and take control of those pieces. And as adults, you and I have a hard enough time doing that for myself. So for a young person with a developing brain, that's a really, really big ask. And I think we need to start getting more thoughtful and more strategic about how we're talking to patients and families about social media use.
That's fascinating. Something else you said struck me, that this is happening internationally. And we didn't plan on me asking this, but so do you mean Western Europe, or are we talking all the major continents all over the world that we're seeing this?
Yeah, where we have data, we're seeing it all over the world. Asia's not immune. Europe's not immune. Big data out of Australia and New Zealand. Certainly some of the kind of poorer SES countries, we don't have as robust of data, but we know that it impacts people there too. Now, the flavor of eating disorder is different and can be influenced by different kind of social cultural factors. And so there's a lot of interesting data about that. But if we're going to say, capital E, capital D, eating disorders, meaning a wide variety or wide spectrum of behaviors, we're seeing that all over the world.
And are you seeing equal increase in men and women?
Yeah, it's a good question. Early data still seems to suggest that the pandemic has had a particularly strong effect on young adolescent females with eating disorders, but that is not to say that it hasn't affected males in different ways. And certainly males represent, a really underrepresented, understudied minority in the eating disorder field, but we are seeing them and recognizing them with increasing prevalence, both on the outpatient and the inpatient sides.
Okay, so can we talk about the pathophysiology of eating disorders? We don't talk about it very much, but can you describe it for us?
Oh gosh, yes. Where to even begin? I think I'm glad you asked this because I think the more we understand the pathophys of malnutrition and refeeding, the more excited we are as pediatricians to get to treat it. I think it's okay to say that these are really challenging illnesses. Our young people can be challenging, and so to view it through that scientific lens, I think is actually really important and kind of fun. So maybe Tony, let's start with some of the acute complications of malnutrition, and we can work our way back through the refeeding process, which also has kind of a unique series of medical complications. So I'm going to tailor this to kind of the inpatient setting since these are hospitalists on the call. Some really salient things. Let's start with just temperament and personality changes in acute malnutrition. And that has ramifications for treatment in the hospital, the way our patients act in the hospital, and the way that we approach our patients. In acute malnutrition, we know that there are both white and gray matter volume reductions in the brain. And they're preferentially reduced, or those volume reductions are preferentially in the kind of frontotemporal regions responsible for things like executive function, our ego, the way we reflect on ourselves. And so if you think about that, if you view your patients through the lens of they've got these big old ventricles because they have lost actual brain volume, I think that allows us to have a lot more empathy for some of the behaviors we see in the hospital. It's fascinating because as patients become more malnourished, they become more anxious, more rigid, they have more body dysmorphia. And in my mind, I really attribute that to those changes we can see if you throw our patients in an MRI scanner, which we're not doing, right, other than for study protocols. But I think that's just an important piece to keep in mind.
So there's white and gray matter reductions, and specifically in the frontotemporal regions, and you're saying that it can affect decision making or coping mechanisms, which, when they get more and more malnourished, especially when we see them in the hospital, will explain some of the behaviors they have while we're refeeding them.
That's it. That's exactly it. Yep.
Okay.
The other kind of big medical complication we think about when folks are coming into the hospital, right, is electrolyte shifts and changes. The one that worries me the most that I think doesn't get enough attention is hypoglycemia. And I want to talk about that a little bit because we have, when I think of what kills our patients, right, it's cardiac arrhythmia, cardiac arrest. It's suicide, actually, is what makes mortality really high in anorexia nervosa. And then I'm going to go out on a limb and hypothesize that it's also hypoglycemia that we're just missing or not catching. And what's interesting about that, right, as a hospitalist, we're often checking preprandial glucoses, like in the case of diabetes, right, to dose insulin or whatever. But our patients are really at risk of hypoglycemia after they eat. Their body is seeing maybe carbohydrates for the first time. We know that, having not had carbohydrates for a long time and having that sudden influx of carbohydrates causes this really impressive and profound release of insulin, which shuttles glucose into the cells, and then we get whole body depleted of glucose. And so I suspect that really profound hypoglycemia is actually causing some of the cardiac arrest we see in our patients.
Really?
So when I get a really sick patient in the hospital, and there's not good evidence to guide this, so, use your judgment of what that means, very ill or critically ill, I am checking postprandial glucoses, maybe 30, 45 minutes after meals on my patients who are very ill, because that's when I'm worried about their glucose totally dropping.
And so you don't think that it's with that insulin spike, they're getting glucose shuttling in, but they're also going to get potassium shuttling in with it. You think if they're having mortality, it may be hypoglycemia.
Yeah. And certainly we worry about phosphorus, potassium, sodium, those other pieces too, more in the context of refeeding syndrome, which tends to come 2, 3, 4, 5 days into the refeeding period. But hypoglycemia is what I really worry about right at the beginning of the refeeding process.
Interesting. And that's when we're starting, like for us, we're starting low, 25, 50% of their caloric needs,
That's right.
and then building up from there. So even that small amount, which is a lot for them for probably what they've been seeing,
Yeah.
drop their sugars.
That's exactly right. That's exactly right. Right. Or they roll into the ED and they've got a glucose of 45, right? So you figure their body has adapted or has been living in that kind of starved state for a long time. And the way I will often pose it to patients and families is like, wow, thank God that you have a body that has been trying to protect you, right? Because someone else with a glucose in the 40s might have had a seizure. And so again, just really, right, as a hospitalist, really leaning into the medical ramifications and getting the whole family to some degree kind of anxious about this diagnosis, right? You're gearing them up for what's going to be a battle that lasts well beyond the inpatient hospitalization. So leaning into those pieces is important.
Well, so speaking of, we were gonna do this later, but you kind of brought it up.
Yeah.
Why? This is kind of a simple question. But we may have residents, medical students, or even hospitals who don't take care of these kids a lot.
Yeah.
We touched on it. So the major causes of death in children with eating disorders and anorexia specifically, but all are arrhythmias or suicide. Is that, and maybe hypoglycemia. Is that how you see it? As that's why we care, because the mortality from those things is significant?
Yeah. I mean, the mortality really, when you look at, again, meta-analyses, there's a range, but we think of mortality as 6 to 10%, and compare that to a second for other pediatric illnesses, right? Like even think of ALL, right? Leukemia, like mortality rates aren't that high anymore for that. And so we really need to be, as pediatricians, talking to families as if this illness is like a cancer, because these kids are going to go on to have either chronic and severe, really enduring anorexia nervosa, which frankly is no good quality of life as an adult, like, or they might pass away. And so really, sometimes that hospital first touch point can really set the stage for if this young person is going to recover or not, because the ramifications are profound, and the public health burden is profound too, right? If we want to talk about it from a systems level point of view.
Now, is that all the pathophysiology you want to discuss? Because I kind of jumped to the mortality.
Oh man, no, there's so much more, and I certainly cut me off if I'm boring you, because I could.
No, you're not.
Wax and wane about this all day. Yeah. So some other things I think just to be on the lookout for when patients present initially. Elevated liver enzymes is something that we often see on presentation. I don't know if you guys are seeing much of that on your inpatient units.
We have.
Yeah. And it's not something, again, that you may change the course of while the young person is inpatient, but it's something you want to point out, and so that the outpatient folks can continue to track the improvement, and B, again, to let families and patients know just how sick they are. In anorexia, often there's a feeling of I'm not sick enough or I don't deserve treatment. And so again, really leaning into those medical pieces is important. But I want to talk about kind of the pathophys of the liver enzyme elevation, just because I think it's interesting. So there's two different kind of mechanisms for elevated ALT and AST in anorexia. The first one is just malnutrition itself. We don't exactly know the mechanism of that. It could be malnutrition related hypoperfusion of the liver itself causes just a mild transaminitis. And kind of in parallel with that, we think that there is some degree in severe malnutrition of just autophagy, right? The body is so very malnourished. It's literally eating itself to release energy stores that are stored in the liver. Yeah. So we expect that to improve, but not during hospitalization. That's going to be 2, 3, 4 months into the process of weight restoration that we expect to see those things improve. So you don't need to track that, every day in the hospital. The other kind of interesting correlate of that is that the refeeding process itself can cause kind of a transient hepatosteatosis, where we can also see elevated liver enzymes, again, just from that really kind of profound reintroduction of carbohydrates and glucose shifting into the cells to build back up glycogen stores. Both of those tend to be a pretty mild transaminitis. So we're not talking like, Tylenol overdose level hepatitis, but it is very, very common to see ALT and AST in the hundreds. That is pretty common.
Okay.
Yeah.
Ironically, the episode right before this was a hepatitis episode on this severe hepatitis sweeping the country.
Yeah. Okay.
So people who have just listened to that will be hearing this, and it'll be interesting. So in the hundreds, with refeeding you can get.
That's right. Exactly. This should not be severe. If we're in the thousands, maybe you should consider that new hepatitis. Yeah, absolutely. Some other kind of common things being common. We see elevated triglycerides and cholesterol in our patients all the time. Really important to point out, right? Because let's say, I'm sure this is true of UPMC too, but our patients and families have access to their lab values in the EMR or on an app, whatever. And so it's really, for a layperson, right? For a family to see, you're telling me my kid is starving and they have elevated triglycerides and cholesterol. What's up with that? It's really important to point out that that is also part and parcel of malnutrition, right? That's the body trying to mobilize those cholesterol stores and releasing them into the bloodstream to get a quick energy source to the brain and the heart to live. That also is expected to improve with renourishment. But again, don't repeat that in the hospital. We're talking 2-3 months into the refeeding process for those values to improve.
Wow. So hepatitis, elevated cholesterol, all will take months post-discharge really resolve.
That's it. And kind of, going along with the theme of things that you'll find in the hospital, but don't need immediate correction are, you can see pancytopenia, anemia, leukopenia, neutropenia. Really any variety of hematologic impacts are seen. And the most common of those is actually leukopenia or low white blood cells. About 50% of patients with kind of classic anorexia nervosa restricting type will come in with leukopenia. And that is, if we're going with this theme of kind of the body shutting down, slowing down, going into hibernation mode, that's what the bone marrow is doing too. It just doesn't have enough energy to produce those blood cells.
Wow. So all these lab abnormalities really are linked to just a pure lack of energy, which we know with anorexia occurs.
That's it. Now, interestingly, for clinicians to know, even if there's leukopenia and neutropenia, we do not tend to see increased infection risk in patients who are severely malnourished. Now, am I advertising that to patients and families? I am not, right? Because I'm, again, leaning into the severity of the illness, but just good for us to know kind of on the back end that typically we don't see increases in infections in these patients.
Yeah, I mean, it's easy to lean into the severity with a 6 to 10% mortality rate. That's high.
That's it.
That's very high. And honestly, I thought it was higher. So I'm happy that it's not 15 because that's where I thought it was living.
Yeah.
But okay, this is great. What else do you have?
Yeah, sure. So, I think an area of kind of emerging research is in renal implications of malnutrition. That is something that's overlooked. Really, I think probably the meat of this issue is that, right, when we look at GFR as a surrogate of renal function, most of our measurements are creatinine based, right? Like the Schwartz bedside equation or whatever. But because anorexia has so much lean muscle mass wasting, they just aren't making a lot of creatinine to be measured. And so it's just not an accurate reflection of GFR when we're using creatinine-based measurements in patients who are severely malnourished.
So our measurements aren't accurate for them.
That's it. Exactly. So, we're looking at GFRs. Maybe every once in a while you're going to see one below 90, below 70. But the reality is probably a third to a fourth of our patients have renal impairment, AKI, on presentation. We're just missing it because we're using those creatinine-based measurements as opposed to like cystatin C, which we're not doing yet at UCSF, but that would be a more accurate kind of reflection of renal function in our patients. When you look over the longer term, so there's this great little cohort study that followed adolescents who had been hospitalized for anorexia nervosa, follow them for 21 years out. 5% of them will end up developing chronic renal failure, needing hemodialysis. So again, the impact of that really isn't trivial. And we may not see it back when they're adolescents. So even if you're thinking, mortality 6 to 10%, okay, that's better than I thought. Really, like just thinking about the long-term burden of these young people who don't get better, it is really profound.
I didn't realize it was that. Wow, 5%. That's good news.
Yeah, right.
Okay.
Yeah. Other follow-up.
This is all new. This is great.
Oh, good. I'm glad. I don't mean to be too doom and gloom, right? But other follow-up studies have shown that like 20% of adolescents who had anorexia nervosa and were hospitalized are not able to financially like support themselves as adults and as young adults. And so again, just thinking about how many of these young people maybe get services when they're young and maybe don't, maybe they don't end up in the hospital. Maybe, they're lucky and they go on to leave relatively functional lives, but in many ways are still very incapacitated. And I think we have to factor in that burden to how we're conceiving of these young people.
That's interesting on a number of levels, because you wonder if it's the eating disorder itself or also concomitant other mental health issues, depression, anxiety, or anything.
That's it. That's it. Yeah. And it's hard to say, we know certainly eating disorders are highly comorbid with other behavioral health conditions, depression, anxiety, and OCD being kind of the big three that come to mind. But honestly, it can come with any comorbidity. We see it all.
Oh, wow.
Right.
Okay. Do you want to move on to admission criteria?
Let's do it.
So when should we be admitting somebody to the hospital who has an eating disorder?
Yeah. So we have a really good position paper to guide us on this from the Society of Adolescent Health and Medicine. It's in 2015, if you want to look it up, with really, really just like clear-cut admission criteria, which is really helpful. And these are pretty widely adopted across the country in tertiary academic centers. So we do tend to follow these. I'm going to highlight just a couple of the salient ones and then talk about maybe a little bit of the wiggle room in terms of admission. So the big first one is just body weight itself. Severely low weight is a risk factor for the refeeding syndrome. And so we know, let's say, again, a patient has a body who is clearly protecting itself and has stable vital signs. If someone is really below 75% of where they should be according to their historical growth curve, it is really, really hard and frankly not safe to begin that refeeding process at home. So we are hospitalizing just for severely low weight at our institution at times.
So under 75% of where they should be based on previous growth curves. That's what you would call.
Yeah. So, and that's a little bit controversial. We can talk about that too. The actual guidelines in this position paper talk about what's called the median BMI, right? Or that 50th percentile for age and sex growth charts according to the CDC. Increasingly, that is becoming a research metric, a way to standardize how we're talking about weight, but less clinically relevant, right? Because if a young person has been growing 95th percentile for weight and BMI since toddlerhood, they got no business being at the 50th percentile. If that young person is at the 50th percentile, right, for, again, weight, BMI, whatever, they are profoundly weight suppressed. They are going to be just as medically ill and just as psychologically ill, if not worse, than patients who are riding that first percentile BMI curve.
Now, that's interesting because I think a lot of people may overlook that. So, because they would say 95th percentile, okay, that's very high. Right. 50th percentile, that's the medium. They should still be fine.
Yeah.
Maybe, but you're saying they could still be very ill.
And I'm not even going to say could. I'm going to say they are severely ill.
They are. Okay.
Yeah, because what we know is, I'm going to call it weight suppression, that differential, right? Where they were historically growing and where they landed. That change is what, again, accounts for medical and psychological illness. And we have a lot of data to back that up. And so I think this is where, in many cases, I have to bring a big slice of humble pie to my encounters with patients and families, because a lot of these patients developed an eating disorder after a doctor encouraged them to lose weight. And so maybe it wasn't you and maybe it wasn't me, but it can count for a whole heck of a lot to look a patient and a family in the eye and say, I am so sorry that we caused this harm, and I'm going to do everything in my power to partner with you so that we can figure this out.
I want to explore that a little, because we are telling our morbidly obese patients to lose weight.
Yeah.
Is it that they started losing weight and developed an eating disorder where they so severely restricted their calories that they caused that this damage was then occurred on their body?
Right.
Versus if they had eaten properly and exercised and gradually lost weight, this would likely have not happened. Is that correct?
You just can't predict it. And I think that's what makes this nuanced conversation with patients and families so challenging.
Okay.
I realize I come at this with a certain bias. So I understand that morbid obesity certainly has its own kind of medical and psychological comorbidities. I'm down with that. Okay. And for the genetically vulnerable person, right, who starts to lose weight, it is often that little bit of weight loss, that taste of restriction that triggers a full-blown eating disorder. Again, with all of the morbidity and mortality that entails. I think of it kind of like, in cancer, we talk about the 2-hit hypothesis.
Right.
Right. They have the genetic mutation and then they need something else to kind of tip it over into cancer. I think of this the same way. It's a genetically vulnerable person or someone with a certain personality temperament that puts them at risk. And then there's another hit. Is it the pediatrician saying they need to lose weight? Is it that they got a GI illness and unintentionally lost a little weight and someone gave them a compliment for it, right? It tends to be these two kind of pieces in parallel that kind of tip someone over into developing a full-blown eating disorder. Does that kind of make sense?
It does. So there had to be something there in that person where there's a predilection to develop this with the right environment. Right. External factors. Is that right?
Yeah, that's it.
So it's similar. It almost struck me initially as like a gambler. Not to make light of it, because I'm not. But if you never gamble, you never find out if you're gonna be like someone who's addicted to gambling. But it's that one time, and you win, and it's that high, and then all of a sudden you've become one.
That's it, right? So that begs the question: how do we? Again, I know this is more of an outpatient issue, but how do we talk to our patients who are morbidly obese about losing weight? And I'm going to make a strong argument that it should be about purposeful, joyful movement because it feels good, right? Or because it's spending time with family. Pediatrics has a really nice paper about how family meals is actually one of the most salient interventions for weight management for patients and families to sit down, have a meal together without distraction. So in our practice, we're not talking about calories and weight loss goals and diabetes. We might be tracking some of those things right behind the scenes, but that's not the thing that we're going to talk about with the young person because again, we just don't know who's genetically vulnerable and size is only one kind of metric of health. And so gosh, that's a whole nother podcast, Tony, but I appreciate you talking through it with me.
That was fascinating because it brings up the question, I guess, that we have throughout history, people have been the same. And now we're seeing this gigantic increase in eating disorders.
That's right.
And so if we're saying that there's a predilection for it, it had to have been that multiple things, like in the pandemic, they were isolated. They were removed, like you were saying, from their activities that gave them joy. Like I had a number of patients who were on different sports teams and that was taken away. Yeah. And then something happened and they got triggered and they fell into this.
That's right.
So you had to have done all these other things and then it popped up. So
exactly.
It's just so interesting. Cause when you and I were growing up, there were all of these, cause I always assumed growing up that this was because of this desire of society for thinness, in models, in magazine covers. And growing up, we didn't have the internet. I didn't have the internet. There wasn't social media, but there were magazines everywhere. There was Teen Beat, there was Tiger Beat, there was all this stuff. And it was always the same kind of person on the cover that was Photoshopped.
Yeah.
But it didn't trigger it to this degree. So it's just a perfect storm, I guess is the best way to put it.
It's a perfect storm. I think that's exactly right. And then remember not to discount, often these are patients with low self-esteem. And so it's not always about body image, right? It is the feeling of restriction. Just think about our society at large, right? How much diet culture in the diet industry just kind of permeates everyday life. So you've got a kid at home from school. Maybe they were really successful in school. Now that's kind of been taken away, right? That's not where they're getting their self-esteem or their sense of identity. So what's another thing they can do to feel good, right? Well, society says carbs are bad. So you take a very black and white kid who has low self-esteem and wants to do well or do something right. This is not a kid who's going to cut out a little bit of carbs. This is a young person who's going to have 0 carbs for the next 3 months, right? And so you can see how this kind of thing will spiral. And to some degree, these are things that our society values and rewards. You can see a world in which a, again, stereotypically overweight young person has cut out carbs. They go to the pediatrician with 5 pounds of weight loss and they're praised. Yeah. And a kid with low self-esteem is like, oh, this feels good. This feels good. And so you can see how this might snowball during something like the pandemic. That's just a small example, but.
That's great. That's a really great example.
Yeah.
Okay, so we're saying this back to our original point. We got sidetracked easily, but that was a really good sidetrack.
Yeah.
So for admission criteria, according to the society, is 50th percentile for this ideal body weight and height based on the WHO protocols.
Right.
But you're saying that's more research use now. Yeah. Most people are using something like 75th percent from where they should be on the growth curve they've been on their whole lives.
That's right. That's right. Yep. So that's our big weight criteria. Now, most of your patients who are beneath that metric are going to have vital sign abnormalities. That's going to be more the rule than the exception. So some of the vital sign criteria we use, certainly bradycardia, anything less than 50 while the patient is awake is going to be criteria for us. And please do not fall into the trap of, my child's a runner, right? And so they have a slow, healthy heart rate. They have been told that before. They might have even heard it from a cardiologist. But if there is an impressive degree of weight suppression or eating disorder behavior, anything under 50, I don't care if you're running marathons, that is not okay for a young person. So we'll stick to that pretty stringently. Other, vital signs, hypotension, really anything less than 90/45 for us is hospitalization criteria. And then orthostatics, right? So we look at that change in heart rate from lying down to standing. A change greater than 20 is in that position paper. I'm going to tell you, if we admitted based on that, we would have a children's hospital of no one but eating disorders. And so at UCSF, we actually use a heart rate change of 35 instead.
I see.
And then also, kind of parallel or concurrent drop in blood pressure on orthostatics. Systolic drop greater than 20 and a diastolic drop greater than 10 is also admission criteria. I'm going to ask that you just, right, everyone needs to use their own clinical judgment. Some of this is just about kind of justifying with insurance why young people need to be admitted. So using the whole clinical picture, but those are the guidelines.
Now, I've noticed orthostatics, are they also going to correct similar to the LFTs and the leukopenia you were talking about earlier? Do they take months to correct even after the patient has been refed? Because I have found that they really don't correct sometimes.
It's a good question. There is really only one good paper from 2013 to guide us in this. We know that orthostatics are certainly, I'm going to call it the least sensitive vital sign, like the one that tends to, right, it can be influenced by dehydration or anxiety. And so we're a little bit softer about those orthostatics for sure. The best data we have says that they take about 2 to 3 weeks to resolve or normalize, and they don't normalize until about 80 to 85% again of that target weight.
Okay.
Based on the individual. And so most of our patients are not in the hospital until they're 80 to 85% of their target weight. So yeah, so it's about that 80-85% of target weight where we see those improve. So, again, you got to kind of use your best clinical judgment, but we are often not waiting for those to completely resolve. We are actually not using that as a discharge criteria for medical stability.
And the heart rate criteria you were talking about earlier for bradycardia, I believe that's probably regional, right? Because I know some places will use a heart rate asleep at least above 45 and then awake above 50 or 55. So either of those are a reason for admission.
Yeah, that's exactly what's in the guidelines. Yeah, that's right.
Oh, perfect.
Yep.
Okay. So we've talked about admission criteria. And why do we use the percent of ideal body weight? And so you're saying under that 75th percentile, your risk of having these these vital sign abnormalities goes up.
That's right. And, we see some bodies that are more sensitive. Maybe they only lose 5 pounds and they have bradycardia. Other people can lose 45 pounds and their heart rate is fine, right? So there's just a lot of genetic variability. And so I would just ask, right, not a hyper focus on the weight loss and how underweight someone is, and really looking closely at all the other medical pieces.
One of the things I've noticed, and in terms of, we're going to get into treatment. So why don't we talk about treatment?
Let's do it.
So we talked about orthostasis. That's great. And then, so the types of therapy. Now, we have traditionally learned that if a person's admitted and they're under a certain percentage of ideal body weight, and you kind of talked about pathophysiology, their brain literally cannot tolerate or can't understand therapy for their underlying disorder. So they, cognitive behavioral therapy or anything won't work at that point. Is that right?
Yeah, that's right. That's how we kind of conceive of treatment for these patients. And it can feel pretty backwards as a provider, right? I think as pediatricians, we're trained for adolescents to really foster their resilience and independence. And in some ways, this is like reverting to toddlerhood, right? We are asking and really insisting that weight restoration take place before engaging the young person in being a part of their food choices, in thinking about why the eating disorder happened. Exactly. And so the therapy that we really recommend and has the largest evidence base is called family-based treatment. And the beginning part of that is all about weight restoration and empowering caregivers to figure out how to weight restore and medically stabilize the young person. And that's before really any individual therapy takes place at all.
And now I have had a number of cases where the patient will tell me after they've been admitted for a while and they've gone through the refeeding process and their ideal body weight has increased in percentage. It'll be from one day to the next, they'll say, I feel like a veil or something cloudy has been lifted on, I feel like that was cloudy before in my brain and now it's gone. And I just feel like just better all of a sudden. Yeah. Is that, since you were talking about the shrinking of the gray and white matter, is it that they've been fed enough that their gray and white matter are now in normal size?
Yeah, that's a good question. I don't know that we have that kind of granular data. I do know with weight restoration, many of those changes, neuroanatomical changes, are reversible. But right, I think you just lean into that. That is giving your brain the energy that it needs. That's giving your heart the energy it needs, right? All of these things, you're seeing the body come back online and pointing that out to families, right? Like, food really is the medicine here. There is no medicine for anorexia nervosa. We can throw meds at it, but they're probably not going to work. So really kind of empowering families to start to think of food as the best medicine for this problem. And it really is.
And here we should probably put a disclosure in for those listening, because if they're going to look this up, I'm just going to say it, that Amanda was kind enough to allow me and one of my colleagues, Dr. McCormick, to work on a paper with her on refeeding syndrome and inpatient management. So we have collaborated in this area in the past. So we start at, in terms of refeeding, typically around 25 to 50th percentile, slowly increase and look for refeeding syndrome. And you were saying if it's going to occur, it's about 2 to 4 days in. Is that right?
Yeah, I think, to keep it real simple, just within the first week is really the highest risk for refeeding.
And am I right? The studies show that refeeding syndrome doesn't occur a ton with eating disorders.
Yeah, no, it doesn't. And I think part of the problem with talking about prevalence of the refeeding syndrome is that so many different hospitals have different kind of refeeding protocols, right? They're really not standardized across the country. And in parallel with that, refeeding syndrome is this really kind of vague constellation of symptoms. There's no one particular kind of marker or metric that moves someone from not having refeeding syndrome to having refeeding syndrome. So it's really hard to talk about prevalence, right? Really, probably the best surrogate marker we have for refeeding syndrome is hypophos, low phosphorus, is kind of considered the best surrogate marker. And our best estimates is that about 14 to 15% of patients will develop hypophosphatemia in the setting of refeeding. So it is, relatively uncommon. We see it at least once a week in our hospital. And when managed appropriately, in the context of a good inpatient team who knows what they're doing, by and large, it is treatable, and you're not seeing a lot of the really, really scary ramifications.
Fascinating.
Yeah.
Now, you talked a little about this, and one of the things we don't know about as hospitalists is what happens when patient leaves the hospital. And I have read this, that family-based therapy is the standard at this point for outpatient treatment for children and adults with eating disorders. Is that right?
Yeah. Yep, that's it. That's what we're recommending.
Is that what? Can you broadly describe what that is for us?
Yeah, absolutely. So family-based treatment was developed way back when in London. It was called the Maudsley method, and then kind of brought and adapted to a population in the United States. It is a 3-phase treatment that really involves and empowers caregivers to take complete control of weight restoration and feeding their young person. That is phase 1. Again, this idea that we can do no real deep digging in terms of therapy until that brain is renourished and the body is in a medically stable place. So that phase 1 really, most of the work is with caregivers, figuring out strategies of how to refeed their young person in the home. The way I pitch this to young people and families is, it's not that I don't trust you, but I don't trust that eating disorder right now to be able to make really good choices about nutrition. It still leads to a lot of conflict. So I think it's important to be upfront with families, right? That this is challenging. And the hospital's a really good place to practice, right? So when you have that window, whatever, a week with patients and families, I am saying things like, look at how much food we're providing. You are going to do this at home, right? Notice when your young person struggles and what helps them get through it, because you are going to be responsible for this the minute you leave. So using the hospitalization as an opportunity to kind of capitalize and keep that momentum going in the outpatient setting. Okay, so let's say things are going well, the young person's gaining weight, et cetera, et cetera. Phase 2 then is about a slow transition of independence over nutrition back to the young person in kind of a slow stepwise fashion. And then phase 3 finally is going to be kind of diving into those typical, more adolescent psychosocial issues. The young person's going to have most of the autonomy over what they're eating at that point. There might be a return to exercise or activity if that was, kind of got entrenched or mixed with the eating disorder symptoms, and really wrapping up and setting up the young person for success in the future. So it is an intense process. It's a difficult process. It's a whole family affair. I mean, it's a really full-time job. And so using, again, the hospitalization to really kind of get families ready for the battle prepared can be an unbelievably meaningful step in creating the opportunity for recovery down the line.
That's so helpful to know, because again, we don't really know. We know that it is the next step.
Yep.
But in terms of that, the next step is that they're going to have to get the child to begin taking it on. And then the battles they're having here, they're going to have at home without us.
Yep.
That's good for us to know, so we can bring it up to the family and
Totally.
really kind of show we're trying to ally with them to help their child. Because at this particular time, like you said, their inner eating disorder voice is too loud.
That's it. And remember, just like our patients, caregivers are also living in this world where they're praised for weight loss and being told, messages of eating healthy is better, blah, blah, blah. And so, in some ways, whether you like it or not, as a pediatric hospitalist, you're kind of the de facto therapist while they're in the hospital, having to really help families see just how medically serious this is and what are the changes they're going to have to implement at home to keep up the momentum.
So you mentioned this earlier, associated with anorexia, you said the 3 major other disorders are, and correct me if I'm wrong, OCD, depression, and anxiety. Is that right?
Yeah, that's right. And that's more specific to anorexia nervosa. Every eating disorder has a little bit of a different flavor. I'm sure you guys are seeing more ARFID, avoidant restrictive food intake disorder. We are seeing that as well. That kind of comes with a different constellation of mental health comorbidities. But yeah, I think anxiety, depression, OCD, those are highly comorbid with eating disorders.
And are there ARFID is associated more with? Since you brought it up, what other syndromes did you notice ARFID with? Just so
so ARFID is super heterogeneous, right? Which makes it really tough to treat. There are these 3 big buckets of ARFID. right now. We'll see in the next DSM, but there's kind of this lack of appetite, right? Those tend to be kids who are more depressed or anhedonic, tend to just not have that typical drive to eat. You've got your kids who are very sensory sensitive, right? They have this like really pronounced disgust response to certain foods or textures. Those tend to be your folks with more developmental delay. We see high rates of folks with autism spectrum disorder who fit into that bucket. So that's again, like, right, this whole different kind of etiology that might deserve different treatment. The last kind of bucket is kids who maybe had some kind of traumatic choking episode or vomiting episode, and so they become really acutely afraid of food intake. That piece tends to be more highly comorbid with OCD, obsessive compulsive disorder. So it really does kind of change how you diagnose, how you treat, what you might prescribe, right? So it's just, ARFID's, man, just super heterogeneous right now. And I'm hoping we're going to get more clarity on that diagnosis as we see it more and more.
And now, Amanda, we've had some kids that get readmitted over and over and over again, and some kids that don't. And now sometimes it's because of a lack of outpatient services, which we've all had to deal with the past 2 years. There's just almost nothing. Anything available has a long wait list. And anyone new coming in who has any type of a comfortableness with eating disorders in the outpatient, whether behavioral therapist, social worker, anybody, is full immediately.
Yes.
So there's a lack of services, but what are other predictors for readmission for these kids?
Yeah, it's a good question, Tony. There are a lot of different papers to suggest kind of different risk factors for readmission. I'm going to pull out some of the salient ones. Younger age at presentation tends to predict readmissions. And I think to your point, you said this at the very beginning, but we are seeing the average age of presentation for anorexia go down like 5-10 years ago. Really, the first peak was between ages like 15 to 17. So kind of that middle adolescent period with a bimodal spike really during the college years. Now we're seeing easily this diagnosis is moving into the 12 to 14-year-old range. So just knowing that your younger patients are going to be more sick and have a higher likelihood of becoming chronic, I think is an important piece to keep in mind. Again, when you look at a whole bunch of studies, another really salient point emerges, which is that a low rate of weight gain predicts readmission, as does lower BMI at discharge. So in case I haven't emphasized this enough, I'm sure I'm like beating a dead horse at this point, but aggressive and early weight restoration absolutely portends better outcomes, both in the short term in terms of hospital readmission and long-term remission from illness. So the effect of weight restoration cannot be understated in terms of treatment course. So not only is that about renourishing the brain so we can get them to participate in therapy, but really if we're talking about not letting this turn into a severe and enduring illness, aggressive weight restoration is the best treatment we have.
Amanda, this has been so enlightening and really, really helpful.
I'm so glad.
Now, we've gone through all of my questions, but I always give our guests a chance to say, is there anything that we did not talk about that you wanted to talk about?
Oh, that's a really good question. Can I make a quick plug for the use of medications in eating disorders, particularly in the inpatient setting? Okay. And this is my favorite thing to talk about because actually this research was done in the early 80s in Pittsburgh. And so there was a guy named Walt Kay, who's now at UCSD, who's been doing kind of work in eating disorder pharmacology forever. And he actually sampled the cerebrospinal fluid of malnourished patients with anorexia nervosa. And what he found was decreased levels of serotonin and serotonin metabolites in that fluid around the brain. So I know it is so tempting to say this patient has an eating disorder and they're terribly depressed and terribly anxious. You want to throw on an antidepressant, right? An SSRI. But the reality of being severely malnourished is that there is not enough serotonin in that cerebrospinal fluid for that SSRI to have any effect.
Oh.
Does that make sense?
So there's just not enough there for it to work.
Exactly. And so again, leaning into, you will hear this from families. My daughter is so profoundly depressed and you're not helping with the depression. Yes, I hear you. And depression can be from malnutrition itself. Your child might be super irritable, super anxious, severely rigid, right? All of these things, we know that that is also part and parcel of malnutrition. So there absolutely might be a role for SSRI medications down the line. Maybe there was severe OCD that truly predated the onset of the eating disorder. I am okay with trying pharmacotherapy in those cases, but there is really very little utility in starting pharmacology or any kind of psychiatric medication in the setting of acute malnutrition. So again, food is medicine. Food is the best medicine that we have for these patients, at least at the beginning of their treatment course.
So then I'm going to ask you to take it a step further. And what about kids who are, or patients who are suicidal with an eating disorder, who are extremely malnourished? Even then, you'd want them clearly in a safe place. So a pediatric psychiatric institution that can manage them and keep them safe.
Yes.
And you would focus on the eating first and then start antidepressant. And that may be a hard question because there may be lots of factors you're going to take into consideration.
That's right. Yeah, it's a really tough discussion and weighing a ton of variables. And again, I don't think it's dangerous or necessarily wrong to have that SSRI on board before you believe it may be able to exert an effect, right? But I just want to put that out there because there's so much polypharmacy in eating disorders. And it's just important to know that really, like, time and time again, our pharmacotherapy trials, specifically for anorexia, have been totally negative. If we had a drug for this, I wouldn't have a job, and I would be happy to not have a job.
It's funny. Our behavioral health professionals here in Pittsburgh, our psychiatrists, have always said this to us. And, I trust them implicitly. They're an excellent group. But it's nice to know the background information behind it, that these studies that were done here showed very low serotonin in the CSF surrounding the brain. So there's just not enough there until the child is refed. That's
right. That's it.
Anything else? That was a great addition.
Oh, man. No, you're going to have to cut me off.
Amanda, this was so helpful, and I hope we get to hear more of you to talk about this, because you have a lot to teach and we have a lot to learn, and we're always appreciative to learn. So thank you very much for your time.
Yeah, you got it. Thanks for having me. It was fun, Tony.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine, for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast. It takes you to a web page. Create a free username and password. Answer some questions that I write that are not hard. And that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi@chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.